Good evening and welcome to COVID-19 and the Vaccine, a webinar brought to you by the Essex County chapter of the Links Incorporated. I'm Darla Miles, a reporter for WABC TV in New York City and a member of the Bergen County chapter of the Links Incorporated. I'd like to introduce you to the incredible group of doctors that we have with us this evening. Dr. Pierre Vigilance is an adjunct professor at the George Washington University School of Public Health and principal of Health Up Strategic Advisors. He also served as the health commissioner for Washington, D.C. and Baltimore County, Maryland. Dr. Karma Warren is the president of the Essex County chapter of the Links Incorporated, assistant professor of emergency medicine at Rutgers, New Jersey Medical School, and she's also a member of the New Jersey Department of Health COVID-19 Professional Advisory Committee. Last but not least, we have Dr. Wayne Riley. He is the president of SUNY Downstate Health Sciences University and a member of the New York State Vaccine Equity Task Force. Thank all of you all for being here this evening. We are very thrilled you're here and we know you have a wealth of knowledge. And I want to start with Dr. Riley. We're going to pivot to you because we've heard a lot in the headlines over the last week or so about vaccine shortages, not enough doses. Even people have been turned away, appointments are being canceled because there is not enough vaccines that have been sent to the states. You're on the task force. Can you provide an update for us on what's going on with vaccine distribution right now?
Well, good evening, Darla. Thank you, and salute to the Essex County chapter of the Links for hosting this very important webinar. You're right, Darla. We are facing, not just in the tri-state region of New York, New Jersey, and Connecticut, a vaccine shortage, but nationally, there is a shortage of vaccine. And this is partly, the fault partly lies in the United States federal government, principally under the former presidential administration, that they did not plan adequately and actually overpromised on how many doses of vaccine could be delivered. So part of this is just simple supply and demand. We have high demand for vaccine, particularly to get healthcare workers and those over 65 vaccinated in the 1A and second grouping around the states. But again, we just have one of those good old-fashioned supply demand issues right now that's very frustrating to those of us who are on the front lines, those trying to get our colleagues vaccinated. I think this will improve with time. Obviously, I have much more confidence in the Biden-Harris administration and the health team that they have put in place to get this fixed, but it's going to take a while. It's going to take about 2 to 3 months for the supply of at least 2 of the vaccines, the Pfizer and Moderna, to catch up. And I'm sure we'll talk about the other vaccines that may come down soon.
Dr. Riley, thank you so much for that. Let's actually talk about the virus itself, and I want to pivot to Dr. Warren, because there can be a little bit of confusion about what's in the vaccine itself. Confusion between what's a vaccine with the live virus, messenger RNA. So can you tell us exactly what is in the COVID-19 vaccine? How does it work? What are the side effects? Kind of give us just a rundown of what's in the vaccine.
Sure. Again, thank you so much for hosting and seeing for tonight. So basically, we have 2 vaccines that are available in the United States right now, the Pfizer and the Moderna. They're both mRNA vaccines. Their differences lie in how they're stored, how they're distributed, but they're both mRNA vaccines. And what's mRNA? Something that I think has been thrown around a lot that people are getting a lot of questions about, but it's actually I call it a natural teacher that teaches our cells to do homework. And what's that homework? To create a protein. in this sense, you're going to create a protein that's equivalent to the spike protein that's found on the COVID-19 cell wall. And I think everybody's kind of seen pictures of this. It's like, I call it like a ball with a whole bunch of different single braids all over it. And so we create this protein that's like the spike protein. So our bodies see this and say, hey, wait a minute, this is not right. And so our body immediately starts to make antibodies for it. And the immune response continues, which at the same time, the mRNA is broken down. Because like I said, we all have mRNA in our body. Once it's done its teaching job, it is finished, it is broken down. So the next time you are exposed to COVID-19, your body says, oh, we know this. We are recognized this spike. We already had this spike. We already have ready for you. So when it comes in and tries to invade your body again, your body immediately starts attacking it with its defense, the immune system, and you do not get sick. So that's how the mRNA actually on layman terms works. But actually most people think it's like a new technology. So to be honest, the mRNA was first discovered back in 1989-90 by a female scientist, which I might add. And they were working on this with other things like the Zika, SARS, CMV, rabies. But it is new in the sense that it's not like our other vaccines, in which at that point we put live viruses, parts of a virus inject inside our body. This is actually teaching the cells to create a protein. And that's one way that it's different. And it does not affect our DNA. So like I said, there are currently 2 approved vaccines. You got Moderna and you have Pfizer. There are two-step process for the vaccination process. There is a 1-shot protein that's in the making right now for a pharmaceutical right here in New Jersey, Johnson & Johnson, and that'll probably come down the line in the next few weeks to months. And I'm sure at that point they will apply for emergency use. But the Pfizer is between vaccine 1 and 2 is about 3 weeks, and the Moderna is 4 weeks. So let's talk about side effects. Side effects are different from adverse effects. And I think people get confused about side effects and adverse effects. Side effects are something that pretty much everybody is going to get. You may not have all of them, you may have some of them, but it's the natural body's immune response and what we want to see happen. And you can have anything from, and it can be from 1 to 3 days. So you can have anything from feeling very tired to pain at the site wherever you were injected, headache, nausea, feeling body ache, feverish. And these are all the experiences that we want people to have, because that means they are mounting an immune response. And so don't get alarmed when you see that happening.
That's really good for you to unpack for us, because again, a lot of people are just unclear about how that works.
Yeah, definitely.
Yes, absolutely. Speaking of how it works, let's move over to Dr. Vigilance, because we want to talk to you about the efficacy of the vaccine. There are 2 obviously approved here for use in the USA, Moderna and Pfizer. And there are a lot of questions surrounding this. First of all, how much protection does someone get? A lot of people think they can choose between the Moderna and the vaccine because of the different dosage and efficacy. If you have the vaccine, does that mean you can go maskless? Do you still need to practice social distancing if you have the vaccine? Can you hug family members? Can you be in large gatherings? What should people be doing, and how much protection do they actually get when they receive their COVID-19 vaccine?
Well, good evening. Thank you, Darla, for the question, and pleasure to be here with this prestigious organization, Essex County Links, and particularly to sit here with Drs. Warren and Drs. Riley to talk about this particular issue. So your question about how effective is the vaccine is a good one, because this vaccine, as it's currently administered by Pfizer and by Moderna, requires 2 shots. So there's 2 answers to your question, which is after the first shot, there's a level of efficacy, if you will, or effectiveness, and that's around about 50%, we say. But after the second shot, which means that you can still contract COVID, you've got about a 50-50 chance of catching the disease. If you go to the second shot, which is 3 weeks out, then the degree to which, and I love that reference that Dr. Warren used, the degree to which your cells have learned the material from the first time in class, they're ready the second time around. That second time around, they do an even better job of ramping up this response to the virus. And at that point, your risk of catching the disease drops to as low as 5%. And that is for both types of vaccine that are currently available in the United States. Now, what does that mean with respect to how we can act otherwise? Now, keep in mind, this means that you yourself may not have the virus be able to get into your cells and replicate and make you sick. That doesn't mean that you don't have the virus in a live form in your person that you can give it to somebody else. You could actually still give it to somebody else. And so all of the measures that we've been talking about for so long with respect to social distancing, mask wearing, being appropriate with respect to contact and cleaning surfaces, all of those things, they still stay in place even with the vaccine on board. And I know that there's a lot in the media about, well, returning to normal as a result of there being vaccine. We're not there yet, and we're not there as soon as vaccine becomes available, because vaccine on the shelf doesn't make a difference. Vaccine in people is what makes a difference. Absolutely. And so people have to not only get vaccinated, but get both doses of the vaccine for the reasons we already articulated. And then we have to still make sure that we are being careful with respect to our contact with each other. So the hugging and the connectivity and the contact that we would love to have with each other has to sort of be held off on for a little bit longer while this process sort of works itself through.
So I have a few questions. Some of the questions have already started to come into the chat, but we're again going to wait until the end of the webinar because we may cover some of this ground. But I'm going to throw out a few questions that are very common. And so whomever of you wants to take it, you can take that at the time. The first one is a big one. It comes from women, and it's about pregnancy and the COVID-19 vaccine. If you're breastfeeding, if you're pregnant, or if you plan to get pregnant, can you get the vaccine?
I'll take it. So first of all, any of my comrades here, we would tell you, talk with your OB. That's obviously a personal decision. The way that the vaccine was, clinical trials is, and if you are familiar with how clinical trials are, you're not going to have pregnant women in it. You're not going to have the very young in it. So the trials do not tell you about whether it's safe or not if you're pregnant. I have known plenty of people who have taken the vaccine that are pregnant, and actually those who are breastfeeding, but that is a decision you need to talk about with your OB about that one.
Yeah, I will follow Dr. Warren in the trials, both the Moderna and Pfizer trials. At the beginning, there were participants who were not pregnant, but women became pregnant after the trial, and they delivered their babies and had no problem. So Dr. Warren's right. Talk it over with your OBGYN. Recently, the American College of Obstetrics and Gynecology did put out guidance for patients and their doctors, their OBGYNs in particular, to encourage vaccination. But again, this is an individual decision that you must talk with your OBGYN about.
And I will say
a step further.
The people who did it. Oh, go ahead. You got it, Pierre.
Well, I'll need to say that personal experience. My wife is a nurse practitioner, a pediatric nurse practitioner. We have a lot of data that we deal with a lot of the time, talking about patient science, etc. We have a 3-month-old. My wife got her first dose of vaccine about a week ago now. After weighing up a lot of the discussions that my colleagues have described here with a pediatrician, looking at the data, talking to a number of different people, and making our own educated decision about what we were going to do, not only for her health, but also with respect to the health of our son. And so we are, I'm mentioning that just to say that this is not just a conversation, but for some of us, it's actually the reality of what we're doing. And I actually got my first dose yesterday. So we're trying to walk the talk.
Yes, and we have a lot of questions about other health conditions, individuals with compromised immune systems. If you have cancer or another condition, an autoimmune condition with a weakened immune system, is it safe to get the vaccine?
Yes, generally it is. But again, we're going to caveat a lot of this, but you got to talk to your doctor. But generally, remember that clinical trials looked at a lot of patients who had pre-existing conditions, of which certain cancers were pre-existing conditions. So obviously, if you're high risk, you fall into that category. You're probably eligible at some point for the vaccine, but please do talk to your doctor. So I guess the basic message is just because you have cancer does not exclude you as a possible recipient of these vaccines.
In the clinical trials, they actually had patients who had lupus and MS. And so those people were a part of the clinical trial. So they actually did all right. But again, falling back to what Dr. Riley said, definitely go to your physician, because actually some medications that you're on may not go well. And so it's always best to have the conversation with your own physician.
Right. And Darla, just to follow up, I noticed one of the questions in the chat about somebody said, well, I have rheumatoid arthritis. Should I get the shot? And the answer generally is still yes. But I will tell you, I have family members, a family member who just got the shot. She has rheumatoid arthritis, and she was laid up in bed for a couple of days because her immune system went into overdrive. So again, she was advised to take it. She called me and I recommend that she take it, but I pre-warned her, you may need to stay home from work a day or two just to let your body recover. And she did just fine. She's back at work and no issues. But again, rheumatoid arthritis, you are not excluded from getting this vaccine. But again, talk to your doctor.
I will say too, I have I'm on immunosuppressant drug medication. And so a lot of those people were not in the clinical trials. And the reason, if you understand, I mean, you're creating a vaccine to cause an immune response to happen. So you're not going to have those people in the clinical trials who are on immunosuppressant drugs, because obviously that might skew your numbers. But I took it and I had no issues. I cannot speak for everybody. I did speak with my doctor about that, but I did not have any problems with that.
Okay, this is really important information, and I know we're answering some of those important questions even as we're just going through the top of this panel. Let's move to Black and Brown communities, people of color, and how they are impacted. It's been widely reported, and because it's a fact that people of color have been more adversely affected by COVID-19 than other cultures. So that sometimes creates confusion when it comes to the vaccine, whether or not there's a specific medical risk because you're a person of color to getting the vaccine. So if one of you or all of you can chime in to unpack that, does being a person of color who has perhaps a comorbidity or has a higher percentage or higher probability of becoming infected with COVID-19, is there any translation to any adverse effects or special medical risk with the vaccine?
I'll jump in here with respect to there's a couple things to unpack here. One is that Black and Brown communities bear the brunt of chronic illness far more than other communities, just overall in general. And by that, I mean our rates of diabetes, heart disease, cancer, stroke, chronic obstructive pulmonary disease, or COPD as we call it, which is bronchitis, emphysema, stuff like that, are all way in excess of that of other communities. And all of those diseases place you at high risk for contracting and having a really bad outcome from COVID. So this is why we say to these populations, and we have multiple times in the past, we did this back with H1N1, we did the same thing before that, that if you were in any of these risk groups, that you benefited more so from getting the vaccine, because if you did get sick from the disease, your disease trajectory and your illness was going to be far more severe, and you were going to have potentially a very bad outcome. So there's that element of things. And then there's this other piece to this, though, particularly in in low income Black and Brown communities, when we start talking about who gets sick, and it's a function not so much of the comorbidity necessarily, but it's a comorbidity laid on top of access and, if you will, exposure, right? So you've got people who are doing essential work, driving buses, taking care of kids, operating in public spaces, taking care of all of the infrastructure things that are needed around us. and they aren't necessarily protected in the way that they need to be protected because of a number of disparities in a number of different systems. And so they are at increased risk by virtue of their employment, right? Which is a whole other conversation to get into, but I think that there's that concern too, right? So we've got a couple of different things there with respect to Black and brown communities, but yes, certainly the comorbidities that we suffer from at much greater rates than other communities do. And that by definition puts us at risk for the disease and for really bad disease outcomes as a result of it, i.e. we're more likely to die from the disease if we contract it.
So does that translate into a specific medical risk to receive the vaccine? Because that's a question that some people have. If I'm at higher risk for COVID-19, does that translate or mean that I have a higher probability of adverse effects from the vaccine?
No.
No, it means that you actually need to get the vaccine.
Yes.
Because if you don't get the vaccine and you contract COVID, you're at high risk of dying from COVID.
Yeah.
And the vaccine is the course of discomfort or the challenge that you may have, as Dr. Warren was describing, the soreness that I had in my arm, etc. That pales in comparison to the significantly bad disease sort of pathway that you can go on if you actually get sick. So no, it doesn't.
And just to let you know, we were in the clinical trials. I mean, we were represented. So, I mean, we were part of everyone who received the vaccine or did or got the placebo. So it's not just one race. It was all races that was involved.
That's right. Let me underscore what Dr. Vigilance and Dr. Warren just mentioned. Think about the three sort of comorbidities that we saw here in Brooklyn, where 70% of our COVID patients back in March and April had one of these three conditions. Number one, hypertension. Number two, diabetes. Number three, obesity. Now, if you think about just our family members, you know, I dare say many of you links have spouses who have high blood pressure. My link has a spouse who has high blood pressure. That is a pre-existing condition. So you need, if you have these pre-existing conditions, as Dr. Vigilance and Dr. Warren said, no, that means you rush as soon as you can to get this vaccine, because we know that comorbidities are the reason why this virus is crafty. It is focused like a laser beam on folks with all these things that we have in the Black community. Number two, I want to underscore something that Dr. Vigilance said. Let's understand that it's not just Black folks who've been walloped by this. It's our Latino brothers and sisters, because they tend to have a higher percentage of multi-generational households, coupled with the type of work they do, where they're forward-facing, people-facing. They bring it home. They have their mother, their father, their uncle, their cousin, etc. And that's another aspect, rather, of why Latino communities, particularly in the Bronx and Queens in the tri-state region, have so been hard hit. In Newark, same thing. Around the country, the same thing. So our brown brothers and sisters are equally, if not in some cases, even higher, been affected even worse.
Definitely. You're on mute.
So again, I want to underscore this because this is one of those things that can quickly become urban myth and urban legend. There is no specific medical risk to people of color who get the vaccine just because they may have a higher risk of contracting COVID-19. I just wanted to drill down on that, just to make sure everyone has the proper takeaway on that. Okay, so let's switch to other possible risks, because again, the internet, disinformation is rampant, especially with COVID-19 and the COVID-19 vaccine. Let's talk about Botox, because I've even had girlfriends to call me. If you have recently had Botox injections, does that mean you cannot get the vaccine, or you may be more prone to adverse effects?
No, not that I know of.
Well, there were reports, and these are scattered case reports of women getting dermal fillers and then develop some sort of reaction. But again, there are no sort of evidence that contraindicated. Now, if you are concerned about that and you get Botox, just put some time between the point you get your Botox and when you get your vaccine. but get the vaccine.
There you go. What about drinking? Alcohol, wine, can you drink it before you receive your dose? And can you consume it or can you consume it after you have completed your doses? Do you have to stop alcohol consumption while you're getting your shots?
No, not that I know of. And I'll be
That's an
honest,
interesting
after I had
question.
my shot, I had about 2 glasses of wine before I went to bed. So I don't know if that's true.
Well,
Yeah.
again, Dr. Warren's right. Obviously as physicians, all three of us will say alcohol in moderation. And we do mean no more than 1 drink a day generally. And actually those guidelines have shifted. It used to be 2 for men and 1 for women. And there's some new guidelines that say, look, we should probably only have 1 anything. But be that as it may, there is no contraindication if you like a glass of wine, like a can of beer, and have a cocktail, occasionally in terms of you getting the vaccine.
Okay, let's talk about COVID-19. A lot of people on this webinar have already had COVID-19. There are many people who have had COVID-19 who are still eligible for the vaccine. If you have antibodies for COVID-19, are you protected? And do you even need to get the vaccine?
This is a great question.
Mhm.
So I think that so if we go back to Dr. Warren's example, which was such a good one about the different things that are sticking out on the top of this COVID-19 particle, there's the main one, which is the spike protein. That's sort of the master key. And there are people who make super antibodies to that master key that are very effective at not having those people get sick. Many other people make other types of antibodies to other things that are on that surface of that particle, and they have antibodies, but we really don't know for how long those antibodies stick around to provide much of any protection. And it's been said that if you get infected with COVID-19, that it's unlikely that you can get reinfected within 90 days of having been infected, but there's a lot more sort of knowledge to be gained around all of this. So first answer to that question is having antibodies does not necessarily make you immune for an indeterminate amount of time. It might make you immune for a short period of time. So do you need to get vaccinated? Yes, because getting vaccinated does, again, I love that reference, takes your body to school. It takes your body to school as you learn what it needs to do to respond to the bug, to the virus, and provides it with a memorized way of dealing with this over time, which gives you a longer period of immunity than just you having the short-term immunity that you can get from having had the virus. I don't know if my colleagues have anything to add to that.
No, I think that's good. You summed it up.
You nailed it.
Here's another big question that we have received about the vaccine. Is a negative COVID test required prior to receiving it?
No, not required to have testing before the actual vaccine. They will ask you some questions that are ascertain if maybe you're positive at that time, also the symptomatology. There is a soft recommendation that was kind of said earlier. If you have been positive for COVID-19, they ask maybe you want to wait 90 days before you take the vaccine, but there is actually nothing that's in paper that says, no, you cannot take the vaccine, and no, you do not need to have a test before taking that.
So let's go back to disinformation and the internet and urban myths and legends. You all may be familiar with a woman who says she's a nurse in Nashville, Tennessee, and she has posted on Instagram that she got Bell's palsy after receiving her vaccine. What can you tell us about that? Is that even true?
Well, well, let's put it this way. It is temporally related, but it may not be causative. So what I mean by that, yeah, she's accurate. She knows she got a vaccine, then she got Bell's palsy, but that doesn't mean that the vaccine caused the Bell's palsy. Bell's palsy is a common thing that happens after many viral illnesses. It can happen after the flu. It can happen after other things. So it's sort of indeterminate or not highly likely that it was the vaccine. So again, as Dr. Warren and Dr. Vigilance know, we know how to treat Bell's palsy should a patient have that. It's the use of steroids, vitamins, et cetera, et cetera. So no, like I said, it's temporally related, but it is highly unlikely or not likely that it's causative.
And it actually is seen in other vaccines. So it's not necessarily just the COVID vaccine. We see Bell's palsy often. I mean, it's a very common effect that happens to people that have. So yeah, the direct cause effect is not there. So please don't run with that one.
I want to skate onto some thin ice here when we start talking about causative and causes and correlations. And it's going to sound like this is a bunch of doctors using some special language to mystify something. And we're not trying to do that.
Yeah.
The fact of the matter is there are going to be cases of where people get vaccinated and various things happen.
Yes.
Palsy, stroke, heart attack, etc. Does that mean that the vaccine caused the person to have those things, that unfortunate situation happen? The answer in most of those situations is going to be no, right? There's going to be a correlation potentially between those two things, but until that happens enough of the time, it's a happenstance. It is not that the vaccine caused somebody to have that particular outcome. And it's very unfortunate that people are having bad outcomes just in general, but it doesn't mean that the vaccine was the reason for them having that particular situation. And I think that's what Dr. Riley is referring to specifically with respect to Bell's palsy. But we will start seeing more stories as more people get vaccinated of somebody got a shot and then they had a particular bad outcome. And are they related? For the most part, no. But there will be circumstances where we'll have to look into and get more information to make the determination as to whether or not they are.
Now, just to pivot, just to add on to that, there are going to be circumstances, but there have been 12 million vaccinated persons already. So, you know, the low numbers that they're finding something happen, don't make that direct causal effect. But remember, 12 million people have already been vaccinated. 1.7 million already have had the first vaccination. So, you know, hey, don't believe it all.
Right, I agree. For example, there's 330 plus folks on this webinar. If Dr. Warren and Dr. Vigilance and I gave every one of you an aspirin, I guarantee you one of you, maybe two of you will have a reaction to an aspirin.
Absolutely.
So that does not stop us from using aspirin. So nor should it stop us from getting vaccinated. Great
analogy. Great analogy.
Absolutely. So speaking of adverse effects, let's talk about just something that happened over the last few days. Sadly, 86-year-old baseball Hall of Famer Hank Aaron passed away. He had received the COVID-19 vaccine January 5th, about 2 weeks prior to his death. And there is one health expert that says the timing between his vaccine and his death is coincidental. Now, this still is cause for concern for some people, saying that, you know, receiving the vaccine and death, like there's just a little bit of concern that there might be some correlation. So even though it's being said it's coincidental, again, there will be individuals who think it might be related.
Sure.
Should there be any cause for concern, in particular the elderly, that age range, 86 and the 80s, where you're concerned that you may pass away within weeks of getting the shot?
Well, thank you for raising that, Carla. I mean, gosh, we all mourn the passing of Henry Aaron. What a great American. I still remember as a young boy the night he broke the record. And as you mentioned, he got his first Pfizer dose at January 5th at the Morehouse School of Medicine, where I went to medical school. The reports I've gotten is that, you know, again, I rely back to Dr. Vigilance on this. Even though it was temporary related, meaning the shot and his untimely demise, it is highly unlikely that this caused it. And the other problem is that we now worry about, I'm a general internist, we worry about for the last year, a lot of people have not gone in for routine care for their diabetes, for their high blood pressure, for their heart disease, for their whatever. And I'm in the back of my mind, I'm thinking, you know, that in some of these cases where it appeared to be, you know, not specifically Mr. Aaron's, but in other cases where people delayed care for other conditions that then led to their untimely demise. So,
yeah.
No, we all mourn Mr. Aaron's passing, but I would draw no conclusion by that fact that he passed away before he could get his second shot, by the way.
Would anyone else like to follow up on that?
I think that last
That
point
was-
that Dr. Riley just made is an excellent one with respect to what has happened in this
Right
last
now.
year with
Yeah.
respect to people and their ability to access care routinely and in the way that they want to access care.
Yeah.
And so I'll put a plug in here, and I don't have any shares in the telehealth company. I'm just saying this because I think that it is important to recognize that the in-person visit may be preferable with respect to your connection with your primary care doctor or your specialist. But if you don't have the ability to get an in-person visit, that telehealth, be that a phone visit or a phone and video visit, is a great way for you to maintain connectivity with your provider over the course of this time where it can be difficult to get into a provider's office. And so that you don't fall off of the journey that you're on with that provider with respect to your medication adherence and just what's going on with you in general. So I think that that's a really excellent point that Dr. Riley just brought up about, are we really well tuned up, or are we falling off the bandwagon a bit with respect to some of our care? And how can we make sure that we're not having that be the case and not having bad outcomes, just in general, COVID vaccine aside, just in general, can we do a better job with that?
And listen to when he said phone, because everybody may not have internet. Our communities are not always able to access the internet financially. So if you have a phone, call your doctor, stay on top of your health, any which way you can.
That's important, that telehealth does not necessarily mean you're on an iPhone or a laptop. You can use your regular phone, a house phone. It is now accessible in this age of the COVID-19 pandemic. I'm glad we got through some of those quick questions that everyone is asking. They're commonly asked questions. I want to continue with Dr. Vigilance and specifically ask you about herd immunity. There's a lot of discussion with regard to that. What does herd immunity mean? How many people need to get vaccinated in order for it to be effective? Can you break that down for those?
I will, absolutely. And the first thing I do when talking to people about this is make sure that we're understanding, we're talking about HERD, meaning the immunity of a large group of people, not HEARD, like immunity you heard about, just so someone told you about it, right? So this is about a large number of people, and it varies from disease to disease. They estimate for COVID, you hear any numbers from 60 to 75% of the population needs to be vaccinated. I'd say needs to be vaccinated in order to have, or for us to have herd immunity. Another way for us to have a herd immunity is in some instances when a disease causes long-term immunity by virtue of you just having had it, then not as many people have to get vaccinated. But because we don't know for how long, as we said before, people who have had COVID are actually protected, we'll say that 60 to 75% of the population needs to be vaccinated in order for us to have herd immunity. And what does that mean? It means that when I get vaccinated, I kind of stop the disease. I can prevent the disease from actually getting into me and reproducing and making me more likely to be able to pass it on to somebody else, someone else who is not immunized against the disease because they haven't been vaccinated. And what's important about that is that we recognize that there are going to be people who either cannot get vaccinated. The vaccine is currently only authorized for people over the age of 16. So everyone in the United States is not going to get vaccinated by virtue of age. And then there are going to be people who choose not to get vaccinated for various reasons. And so we are essentially, by getting vaccinated, facilitating the spread of immunity throughout the community, where we are stopping the bug from being able to move through us into somebody else. And so we are not only helping ourselves, but we're also helping those who are around us and preventing other people from getting infected. So that's the basics of herd immunity. It's really an opportunity for us to help protect communities by doing certain actions ourselves.
I want to follow up on that. Yeah, I'm sorry. Go ahead, Dr. Riley. And specifically, what kind of timing should people expect to achieve that? I'm sure you were going to expound, but I want to make sure we're clear.
Yeah. So, sorry, go ahead, Dr. Riley. I was going to talk numbers, but go ahead.
Sure. We listen to Dr. Fauci, and we should listen to Dr. Fauci, by the way. I've known Dr. Fauci for 20 years. He is a great American, and he's got a terrific African-American scientist in his lab, Dr. Kazmiki Corbett, who he is very proud of, who's been really working side by side with him. And I'm sure you've seen the press reports. But if we get to about 75% herd immunity around the country, and that's estimated to probably occur maybe between Labor Day and Columbus Day in the fall, we may be able to go back to some semblance of normal. I don't call it normal. I call it the new normal, where we still will have to, up until that time, even if we get there in the summer, we're still gonna have to wear masks. We can't go to church. We can't go to football games. We can't, have the great links meetings that I always enjoy going to, the national meetings. This is not the time in 2021 to do that until we get to herd immunity. Now, factoid I just read today, the state of North Dakota, it's estimated that 60% of North Dakota has had COVID. That means they're pretty close to herd immunity just by the simple yardstick, whereas the state of Vermont is only 10% of their population has gotten COVID. So again, you can see how it's going to be regional, and depending upon where you live in some respects, in terms of how the governors open up, quote unquote, based on some level of herd immunity in a region. But if we talk about national numbers, Dr. Vigilance is right.
And we have to vaccinate about 1.3 million people per day in order to reach that end of the year goal of 75% that Dr. Riley is talking about. So if we go along at the current rate of things, my understanding is we won't reach that until sometime in 2022. So again, this is about the longer we take to decide to get vaccinated as individuals, the longer it will be until we get back to the new normal that Dr. Riley just referred to.
Okay. Speaking of getting back to normal and COVID-19 and reaching herd immunities, I want to pivot to Dr. Warren, because you've actually not only been on the front lines of COVID-19, working in the emergency room, you became infected with COVID-19 and you survived COVID-19. And that makes me think about the new variant, because you've obviously survived the initial variant, but as we progress into the next stages of this pandemic, let's talk about that. You have 22 states that have confirmed cases of the variant that has come out of the UK. Just over the weekend, it was Prime Minister Boris mentioned that it could be 30% more deadly and more contagious than the current variant. So this is, again, very concerning. There are also variants in Brazil, variants in Africa, and even reports of variants that have started here in the US. Talk to us about those variants. Talk to us about, if you've had COVID-19, does that mean you can become infected again with the second variant? What should everyone's level of concern be as the virus mutates?
So you're right. There currently is the new vaccine that's been documented in the United States, at least 22 states. What we know about the new strain is that it is more contagious, meaning it has a transmission rate from person to person of up to about 70%. The wording deadly, I think, is kind of a misnomer. It's more deadly because more people are getting it, because it's more contagious, which makes them more at risk for getting the most severe illness from the disease, from the virus. Not necessarily because the strain itself is different, but the contagion portion of it being transmitted from person to person. Let me use an example. I had COVID positive. I became COVID positive last year. I was sleeping in the bed with my husband every night. I exposed my 20 and 21-year-old. And of course, we all isolated and quarantined afterward. But I mean, no one got it. Now, if we had the new strain, they all would have been positive. Everyone would have had positive. And that just brings us back to the original thing, which is wear your mask, wash your hands, do the social distancing, because no matter whether it's the new strain or the old strain, we've got to learn how to keep passing it from person to person. And in utilizing those modalities, we can do that. Also with the new vaccine, I mean, those vaccines are also able to work with the new strains. So it's not like, oh, now that vaccine is done already because it's the new strain that's out. The vaccine is based on the spike protein, and they still have the spike protein on the new strains So again, if you get this vaccine and we work with that and we continue with our mask and are washing our hands, it won't matter that the new strain is out there. What'll matter is that you're doing what you need to do to keep the transmission from continuing.
Yes, and again, Dr. Riley, I want to for you to build upon what Dr. Warren said, because when you have different variants and it may be more deadly, it's because of the rate of infection,
Right.
not because
Right.
the virus is more deadly itself.
Right. It's not more lethal. No.
It's not
Right.
more lethal, correct. So that's a big distinction. I think a lot of people who have logged on to listen. A new variant does not mean that it's more lethal, but when you're trying to slow down a pandemic, you certainly do not want a variant that accelerates the rate of infection.
I mean, the COVID virus by itself is lethal. let's not act like that. I mean, I don't even think people understand how serious this is if you get it. I mean, it is really bad. So you see your friend and he doesn't have it, and you're like, oh, it's not that bad because he did all right. But guess what? He took it home to his grandmother and he took it home to somebody else, and they also did not do well. So it's actually just as bad. It's very virulent.
Right, and I agree with Dr. Warren. Look, the variants are an issue, but that should not deter us from getting the vaccine. The UK variant, the two vaccines that we just talked about, the Pfizer and the Moderna, appear to be very effective with this UK variant. The variant that we're a little bit worried about is the South Africa variant. Now, let's just suppose the South Africa variant is here. I suspect it's here somewhere, by the way. Getting the vaccine is still helpful. Maybe it is that maybe instead of 94% or 95% effective, it maybe goes down to 70% effectiveness. That's still great. We still need to get the vaccine.
Yes, you do.
The number of cases, if we can suppress cases, the virus can't hide. So again, even with the variants, and the other thing, the mRNA technology that Dr. Warren talked about, that's the best explanation that I've ever heard, Dr. Warren, about to a non-nerdy group of doctors like all three of us, and to explain what mRNA technology is. Well, the good news is this technology is so good, they could go back into the lab, do a few little tweaks, and then produce another vaccine that could hit more effectively the variant from South Africa. Now, they don't want to have to do that too many times, by the way, but that does give me some comfort that if this does go that way, this new technology can be manipulated to address it.
So basically, again, just to make sure everyone's has the right takeaway, the vaccine that is currently on the market here in the United States and around the world, they are effective against these new variants of the strain of COVID-19 at this point.
At this point.
Okay. So let's dig into the vaccine just a little bit more. And I have a question for Dr. Vigilance, because I think this is part of the skepticism and apprehension that some people may have when it's their opportunity to get the vaccine. When you hear things about Operation Warp Speed and you think about how typically a vaccine takes years to develop, how long it took for the chickenpox vaccines and the polio vaccine. And so some people are just naturally apprehensive because in their mind, science takes a lot longer to develop a vaccine of this sort. So address those concerns about those people who may be skeptical of the vaccine because of how quickly it came to market. And if the warp speed, if that rate in which this vaccine has been developed has any type of impact on the effectiveness of the vaccine.
I want to start off by acknowledging that it is not unreasonable to question the speed of these developments, not because of the effectiveness piece of things, but because it's natural to do that. And I don't want to sort of just dismiss that as being inappropriate. But that being said, the mRNA vaccine technology that we're talking about is not new, just as coronaviruses are not new. Coronaviruses have been around for a while. We talked about these with SARS back in 2003, that's the sudden acute respiratory syndrome. In 2003, MERS, the Middle Eastern respiratory syndrome. Later in, I think it was around 2012, but before that, we've had H1N1. We've had a bunch of other conditions that have forced scientists to get into researching and trying to understand what this spike protein is and all these other elements of coronaviruses. But what's different this time? What's different this time is, as of right now, almost 100 million people worldwide infected with the disease, right? Millions of people dead globally, right? And I think that the fact that we have such a worldwide situation and has pushed us as a scientific community, and certainly in the vaccine production world of things, to collaborate more effectively with one another, to engage with one another across country agency lines, etc., to try to accelerate the process of understanding and getting our hands around this thing because of its significant impact on day-to-day living. We haven't had a situation like this that has necessarily forced us into this type of corner. And given that, I think that the reaction to that has been a significant amount of resources being thrown at this disease and a significant amount of money being thrown at this disease. And that has also meted out in this speed with respect to what it is that we're seeing right now with these two vaccines that are currently in play, the vaccine that Dr. Warren mentioned, the Johnson & Johnson single dose, and the work that AstraZeneca and others are doing as well. So I think that, again, not unreasonable to be concerned about it, but this is not your regular flu situation. This is not your regular, name it, vaccine preventable illness. And it's not to say that those other illnesses are not important things to deal with, but the number of people they impact and how we are globally impacted by this warrants the kind of urgency that has been put into play with respect to this vaccine and its development, and what will continue to have to be developed into probably a library potentially of vaccines for coronaviruses, because they do change, and we'll see how we work through that in the coming months and years.
Right. Fully agree with Dr. Vigilance. I think, look, let's be honest. We all distrust that this came out under Donald Trump. I disagree with 95.5% of what that man did to this country, but I'll give him 5% credit for getting this vaccine to the market. Now, I agree with Dr. Vigilance colleague at GW. Dr. Jonathan Reiner said they never should have called this thing Operation Warp Speed. It should have been called Operation Safe Vaccine.
Yes.
That's what it should have been called. And, you know, President Trump was basically slapping a new label on the technology that goes back to 1989. So don't take the okie doke on that.
Yeah.
You know, we were all of us were fond of saying Black Lives Matter back in the summer, right? Well, I say Black Lives Matter, and science matters to Black lives.
And again, I think you guys, you definitely have addressed some of those concerns about just the messaging when it was called warp speed. Everyone's antenna may have understandably gone up. But I just, again, want to make sure as we are answering these questions, I'd like to really reinforce so that no one ever walks away with the wrong information. And I think Dr. Warren touched on this a little bit. Even though there was an accelerated rate of production for this vaccine, they weren't starting from scratch. There was already, they were already working from other vaccines. Can you touch on that? If one of you can touch on that for us, please? Because it wasn't, they just didn't come from the drawing board and say, okay, out of my hat, I'm gonna just try this new vaccine. This is already something that had been in the works scientifically. So talk to that. If you can speak to that, I think that would be very helpful.
And in the works with respect to clinical trials, but not for generalized use. And I think that that's an important differentiation because it's something it's relevant to the current situation. The FDA has allowed for an emergency use authorization, which means that the vaccine has been tested, gone through the 3 phases of clinical trial, just like all other vaccines are required to do. But it is moving more quickly to market because there are a number of different companies trying to do that same thing at the same time. And I think that that's why it's an EUA and not necessarily the regular approval, if you will. So this is not FDA approved. It's just that it's gone through this sort of fast tracking, and in part because of, again, the need for us to do that. But to your question about specifically what's been generated in the past, it is related to those previous forms of infection that I mentioned. And a lot of that basic science research that's done at the NIH and the CDC is then used as background for the more specific vaccine development work that goes on at the hands of the drug developers themselves. So you've got government doing its basic science, you've got private industry taking that basic science and working on that a little more to actually produce vaccine. And that combination of data and information and knowledge that we've gathered over the years is what's being brought to bear now and being accelerated in order to get vaccinations out to people.
I just want to point out too, I mean, how most vaccines are put out, or even medications, so forth, you usually have a clinical trials of a population of about maybe 30, maybe 12,000 moving up, but we had about 77,000 people very fast for these clinical trials to start off. And that's actually unheard of to start off. And the reason is why, because this is just worldwide and it's affecting everybody.
You're right. And so that's the whole purpose of this panel, to reassure everyone that this is safe, that they should get the vaccine, that they're not going to grow horns out of their head in 5 years because it was made under Operation Warp Speed, or there's not a live virus in it. So that is important for us to unpack for everyone on this webinar today. Yet there will be people who are still skeptical and leery. What happens to those who decide not to get this vaccine? Dr. Warren, can you speak to that, please?
Oh, sure. I mean, actually nothing happens to those people. There's no fine, there's no penalty for you not taking the vaccine. And actually, like was said earlier, I welcome the hesitancy. I just want you to go and get some more information and talk to somebody and make sure you're more comfortable with taking the vaccine. But like I said, there's no penalty. But I will say this: if you don't take the vaccine and you do get sick, you have the risk of having the most severe illness, and including death. You also have the risk of being an asymptomatic carrier, which is the one that we're really most concerned about, you passing it on and not even knowing that you have it. And then, because you don't take the vaccine, like was said earlier, we just continue to keep this pandemic going on and on and on. And so in order for us to bring it down, we need you to participate in it, or at least make sure that you're getting the information that makes you comfortable enough to do that. I also think that it's going to be at a point where you're not even going to be able to visit other countries, like the yellow fever vaccine. You can't even visit some countries without having that vaccine. And I'm sure that's going to be starting to go into play here. Or you might have a job with the private employer that says, hey, you know what? You can't have this job unless you're, COVID vaccinated. So, I mean, it's moving in that direction, and people need to get ready for that. You can't even visit some countries now, let alone some states in the United States, unless you've been COVID tested within 72 hours. So I think that's something that everybody should take in consideration.
That's right. Links like to travel. Dr. Warren is right. There will be countries around the world that we all love to visit with our spouses that will say, you cannot come into our country unless you have. If you have children who are military age, they will not be able to go into the military and say, I don't want the COVID shot. When you sign up for the United States military, you take every shot they tell you. Many of you links are lawyers. You know that some of your clients are already calling, can I compel my employees to take the shot? That will likely happen once the FDA approves this, gives the formal full approval.
Private companies can do what they want with their employees.
Employers can say that. If you don't think it can't work here. So the hassle factor of not getting a vaccine will be high in many parts of your life, whether it's travel, et cetera, as Dr. Warren and I just mentioned.
Thank you, Dr. Riley. And I have to remind you, there are those on this call, on this webinar, who are not members of the Links Incorporated, and they like to travel too.
That's right. That's right.
We have a lot of people who are here to get this valuable information. So we will
traveling
to listen, right? I want to actually continue with Dr. Warren for a second, because I asked you, a common question is, what happens if people do not get the vaccine? We've addressed that. Will this ever go away? That's a big question that we're hearing. We have to start taking an annual COVID-19 vaccine the way we take an annual flu shot. And I would direct it to, I see Dr. Riley also wanting to chime in. So if someone can address that, people want to know, will it go away? yeah, this is the new normal, but will there be a semblance of normal? Like, for example, we're not worried about polio anymore. We're not really worried about MMR, mumps, measles, and rubella. So, kind of what? Give us a little hourglass.
That's interesting that you asked that question. I think had you asked me before we got a new president, I probably would have answered, yeah, we're in this long haul. We're going to be in this for a long time. But now we have our leadership in our country that understands how serious this is and is putting protocols and policy into place that will allow us to start tackling this a little better. And so now, I mean, I do think it was said earlier, we're definitely going to go into the winter and maybe into 2022. But I do see us moving in a positive direction where we will get to that place. But if you had asked me, maybe last week, I would have said, no, yeah, we in here for a long time. But I do have hope that I think we're going to get in a better space. There currently is no plan, though, for a second COVID vaccine. The key is to get this first vaccine. But I will say, if the immunity starts to lessen or the cases start to go up, which was also said earlier, we can easily give a booster like we did with kid vaccines, or we could do another vaccine annually like we do with the flu shot. So, I mean, the potential is there and the ability is there for us to do that if we need to.
Right.
But right now, no, there is nothing set in place for us to do more than the two-step vaccination or the one-step when that comes out, and then the other AstraZeneca.
Right, Dr. Warren's right. Viruses never go away. They just lose the opportunity to infect. And the other part about these vaccines, although we don't have firm data, the preliminary data suggests that the immunity you get from a vaccine may last a year, maybe two. That would be great. Even if you need a booster shot, as Dr. Warren said, in 2022, that'll be easier. Because we'll have more supplies. We'll probably have 6 different vaccines by then. So again, I have much more faith in Joseph Robinette Biden and Kamala Devi Harris than I did with the folks before.
Yeah. Definitely made a difference. Definitely made a difference. I think for most of us physicians, we were kind of like, somebody's listening to the science finally.
I want to make sure that we're clear on something. This is not to take away at all from what Drs. Warren or Riley had just spoken to, but you mentioned, Darla, we're not as concerned about, say, measles, mumps, or rubella as we once were, but we are, right? Yeah. Because, and there's a famous poet, James Todd Smith, some of you may know him as LL Cool J. It's like, don't call it a comeback, right? It's been here for years, basically, right? And it's a whole other situation we could get into here. Point being that don't call the measles didn't come back by itself because it became more virulent or it became sneaky or crafty like the coronaviruses, etc. Measles came back because people stopped getting immunized.
Yes.
Right? Vaccine hesitancy is now among the World Health Organization's top 10 leading causes of death, really. It's like people not getting vaccinated.
Absolutely.
And there were certain communities in the United States that recently can be associated heavily with, or they are the cause of, the significant upswing in measles cases in the United States, because people said, look, I'm making this decision not to get vaccinated. And they weren't one-off people in different communities. They were particular groups in particular communities. Mm-hmm. And those numbers, that data is not fudged. It is not, right. It is bona fide data. So we may have this idea that we've taken care of vaccine preventable illness in a number of different ways, and we have, but we don't hear from all the people who we prevent the disease from. But we hear from the cases, and the measles case count in the United States shouldn't be what it is. No. But it is what it is because of vaccine hesitancy. If there's one example of why to get vaccinated, measles might be it.
Right. No, let me follow Dr. Vigilance's point. And again, this is where Black folks sometimes take the okie doke with this anti-vaccine crap, anti-vax. That drives me nuts. You have 2 NBA basketball players, Dwight Howard and I think Arnold Porter Jr., who last spring said they didn't believe in vaccines. I almost hit the roof when I heard it. I called my friend at the NBA Players Association. I said, do you guys have doctors that talk to these players to get them to not spout such nonsense? And I said, I assure you, their Black mothers made sure they got all their shots.
Absolutely. Dr. Riley, we're going to have a separate panel with you later, because we like your analogies. Okay. Okay. I want to get through a few more questions with our panelists, some of the basic questions before we go to the Q&A, because we do have a lot of questions coming in. And I want to pivot back to Dr. Vigilance, because you have such experience in vaccine distribution. You were the former health commissioner for Washington, D.C. and Baltimore County, leading the local responses to the SARS outbreak in 2003 and H1N1 in 2009. What are the biggest concerns, in your opinion, at this point when it comes to distribution of the COVID-19 vaccine and communities of color?
And I have to give a shout out to your national president, Dr. Kim Jeffries Leonard. She and I worked together in Washington, D.C. Very much appreciate her support and hard work for us and the citizens of the District of Columbia at our time together there. So shout out to you, Dr. Kim Jeffries Leonard. So concerns, I mean, there are multiple. And when we were setting up mass vaccinations in Washington, D.C., we were very cognizant of the fact that some communities were going to be more hesitant than others. That didn't stop us from being in those communities on a weekly basis, providing access to the same clinical opportunities that we provided in other parts of the city. I think, though, that in retrospect and sort of the learning that I got from that was, though, that you can't really chase. It's kind of like trying to undo a bad diet. If you spend all your time eating a particular way and then you work out, you're only going to get but so far with respect to how well you do. My point is that if we do a better job of engaging communities, Black and brown communities, and engendering trust and engagement before these large events happen, before the need for vaccinations happen, before the need for testing happens, then we don't have as much of a hurdle to get over with respect to the conversation. Absolutely. Right? So the trust element of things, the engagement element of things is something that is hugely important pre-event. And so one of my concerns from the community's perspective is you having not engaged us, having not engaged you frequently enough prior to all of these things happening, it is understandable that you might say, well, wait, hold on. This happened very quickly. Why would I come to a clinic to get something that just came out last week, et cetera, et cetera. So we have more work to do with respect to that. That's one thing. The other thing from a community perspective that's a concern is that myths travel faster than facts, right? And we are very effective, unfortunately, at moving some of those myths around our communities, and they become the truth. And that's something else that we have to work with each other on, which is sort of countering that with the reality of things, like people who understand what they're getting from this conversation that we're having, your members and others who have joined this conversation, taking that information and providing others with that information and trusting and verifying it, and then providing that information to others so that we can expand that out. And I'll say one other thing on the part of the distributors with respect to the concern element of things. And one is that last year, as Dr. Riley mentioned, there was a lot of conversation about Black Lives Matter, and then all of a sudden there was a ton of conversations about anti-racism and equity, and everybody's using the term social determinant of health, and we're all apparently going to do the right thing in 2021 with respect to Black and brown people. The issue there is just like, if you're going to talk that talk, be prepared to actually walk that walk, meaning if you're going to say that you're a department of health, it is a public agency that embraces equity and inclusion, and then you're going to set up your mass vaccination clinic in a location that is difficult for people to get access to without having a car,
wow,
then you're shooting yourself in the foot.
Right.
You're saying one thing and you're doing something else. And you've got a lot of very esteemed individuals listening in on this call who work with municipalities, work with different parts of these systems. Don't let that happen. If we're going to be saying that we're about equity and we're about providing people with the access they need to be actually able to engage in education, housing, economic development, you name it, then we actually need to provide the tools in a way and in places that they can access easily. And vaccinations is one of those particular examples that I can't harp on enough. So we were all over the place doing our vaccination clinics because we knew that people needed to have access without having to drive anywhere. I urge those of you who are in a position to facilitate that sort of thing to do so. There's more to that, but I'll just leave it at that for the moment.
I want to move on to the COVID-19 vaccine in children because we do have a lot of questions coming in with regard to that. Dr. Riley, let's speak to this if possible. Currently, we know that the Pfizer and Moderna vaccine have been authorized for emergency use in people the ages 16 and older respectively. After that emergency use authorization was granted, Pfizer then announced that it was beginning clinical trials for children between the ages of 12 and 15. Now, knowing that, do we have any idea when children will start to be vaccinated? What about babies? What about children under the age of 2 or age of 12 rather? Is it safe? What can you unpack for us right now with regard to the vaccine and kids?
Well, Darla, you're right. Just to fine tune that, the Pfizer vaccine is authorized for 16 and up, the Moderna for 18 and up. Now, you're right. We now need more data to go lower. So that is, we're all anxiously awaiting the data. Now, the good news is when you compare children from birth to about 16, they tend to have less prevalence and incidence of COVID compared to those older than 16 and above, et cetera. So that's why in science, we sort of go where the most impact is initially with our clinical trials. And then once we address that, we then start to go into lower or other groups. So yes, there will be data about children. Probably towards the end of the year or the fall, we'll get some data from some of the vaccine manufacturers. So I would just say, stay tuned, parents. I know you're all worried about your children. The good news so far, as we know in New York City, there's been very low positivity among school-age children. It's really when they get to the teenage years, when they basically don't follow the rules. They get in groups, they have parties, college campuses have outbreaks because these kids are not following the rules. That's where the issue with that segment of young people. So again, we're waiting on the data. The data is coming. So in the meantime, you just have to continue with the same practices Dr. Warren and Dr. Vigilance said for your youngsters: hand washing, not social distancing, mask wearing as early as 2 years of age. Those are still incredibly effective means right now until we get the data. So the short message, Darla, the data is coming. We have to be patient on children.
Okay, great. So we've talked about children. Let's speak to those who are in higher risk categories. This is a big question and really circulates on Twitter, Instagram, misinformation, disinformation circles. But it is a legitimate question with regard to the thousands, the hundreds of thousands of people who have died of COVID-19. But then you have high profile individuals. Former President Donald Trump was infected with COVID-19. Former New York City Mayor Rudy Giuliani became infected with COVID-19. Former New Jersey Governor Chris Christie was infected with COVID-19. They are all over the age of 65. They all have comorbidities with other challenges. We know it was widely reported that they received a treatment that is not widely available. Can you speak to that? What are the drugs and the treatments that are proven to work, and why aren't those widely available to the hundreds of thousands of people who are battling COVID-19 at this time?
Well, you're right, Darla. Let me just say, those three gentlemen did dumb things. I mean, I can't describe it any other way as a physician. They didn't follow the rules. Governor Christie, former Mayor Giuliani, and the president, the then president, didn't follow the rules. They wouldn't wear masks. They didn't social distance. President had things in the Rose Garden that got so many people infected. His White House staff, 22 members of his protective detail and Secret Service got COVID. So again, they didn't do the right thing. Now, the drug that the president got is what we call monoclonal antibodies. There are two manufacturers of those. That is Eli Lilly and Regeneron. That is a drug that sort of gives you sort of extra boost to your immune system by giving you extra antibodies. It's an IV infusion. It is best used right within first 7 to 10 days of you being diagnosed with COVID in order to keep you from going in the hospital. The problem is, and I know this with particularly Black patients, that they sometimes are not offered this. And this is another health disparity issue about, it's not that we get things more than other people. Sometimes we don't get what we deserve in terms of treatment. So if you have a loved one who is within 7 to 10 days of being diagnosed, they're very symptomatic, you should advocate for it. Ask the doctors, am I eligible for monoclonal antibody therapy? Because that's what President Trump got.
Well, I guess in my hospital, where at least 90% of my patient population is brown and Black, we are offering the monoclonal antibodies. And one of the things that we want people to know is you don't have to be rich, you don't have to be special, you don't have to be a star to get the monoclonal antibody. We are giving our patients. Now, you must be admitted to receive that and needing oxygen supplementation for you to get that. But yeah, I'm sorry. No. Those are the ones we're discharging with. We're discharging them. We're treating them in the ER for the infusion is about an hour. We watch them for an hour afterwards, and then they're discharged. And these are the ones that have associated risks that they can go home, but they have some other issues that maybe down the line they may not do well. And so we are offering that to our patients.
Right. Remdesivir, you have to be admitted.
Remdesivir is the one that you have to be admitted for.
And dexamethasone, which is the high dose steroids.
And those are the ones that we want to give the steroids for that need oxygen requirements for that. Yes, absolutely. I'm sorry.
Right, but no, Dr. Warren's right. She corrected herself. Right, monoclonal antibodies is for those who can walk in and out of the hospital to get the dexamethasone. You have to be in the hospital and have to meet certain criteria in terms of your oxygen level.
But Darla, to your point, there is no proven treatment plan for COVID. And I think that's what needs to take home for those people that are on this webinar. We are doing a lot of different things, and you'll find different treatment plans at different hospitals, whether they're adding vitamins, zinc, everybody's has their little potpourri pot of how they're treating the COVID, but because there is nothing that's actual in stone. Something works for this patient, the same treatment doesn't work for that patient. So the key is don't get it. Try not to get it, because we are still working on how to take care of it.
Right.
Really.
The way you prevent it is by getting the vaccine.
Yeah, and I want to just stick here for 2 seconds. Okay, because people ask, because we're familiar with these different therapies, monoclonal antibody therapies. Spell it and tell individuals where they should go to get information so that they can ask for this particular therapy if they are infected with COVID-19. I saw a question pop up, so I wanted to make sure we drill down on that right now. Can you spell that? That was a question. I know how to speak. monoclonal, correct?
Monoclonal. Right.
Monoclonal
Antibody.
Okay.
You can ask your doctor. Your doctor will either send you to the ER. They're also doing it at dialysis units because it's an infusion, which means you have to be somewhere where you can get the infusion of the medication, because it takes an hour just to give you that.
It's not oral, it's IV. You have to have an IV, and then it runs in for an hour, as Dr. Warren said. So monoclonal antibodies, 2 companies manufactured, Eli Lilly and Regeneron.
Eli Lilly, Regeneron, monoclonal antibody.
For the layman person, just ask monoclonal antibodies.
Okay, because I know people are taking notes. I want them to take those notes. Remdesivir, how can they ask for that and spell that for those who are asking?
No, that's only
for people who are well, there are people who are hospitalized, so I want to make sure if they have a family member who's hospitalized that they can ask for that or inquire about that.
They can ask whoever their physician that's on the hospital list, or their physician that's taking care of their inpatient stay, they can ask for that. But for the most part, since that is the only drug that the FDA has approved, most hospitals have that as part of their protocol planning. So remdesivir is not new.
Okay, and is there another therapy they should, any persons of
I mean,
color.
it's also recommended to use the dexamethasone, which is the IV steroid, which we also give to patients that are also admitted. It's not to be given to people at home. It's for those that are admitted that need oxygen supplementation.
And the third is.
And so we're asked by Sherry Winston, can you spell the name again more slowly, please?
Sure.
Steroid. Just ask, you can ask about a steroid.
Yeah, steroid, high dose steroid. That's the best.
High dose steroid. High dose
Steroids.
Okay. Since we're going to stick here because we have so many questions coming in.
Yeah, I see 90. Woo. All right. Let's go. Let's go.
So everyone, I'm going to put my glasses on for this. Okay. How long is the vaccine effective? I know we talked about getting booster shots. Will people, be protected from COVID-19 forever if they receive this vaccine?
Again, like we said earlier, right now, this is just a yearly thing that we're looking at. If we do need to go further than that, we have the opportunity and the ability to do that. But right now, years is what we're looking at, year to 2 years.
Right.
We have a lot of questions regarding allergies. Robin Rhodes, moyitis. They want to know those who have allergies to shellfish, nuts, gluten, peanut. What should there be concerns with regard to getting the COVID-19 vaccine?
Well, again, this is an individual conversation with your doctor, number one. If you have a documented shellfish allergy, not that, I get upset stomach when I eat fish. No, that's not what we're talking about. This is if you break out in a rash, your lips swell, your throat tightens up, that's, more concerning. So discuss with your doctor. Now, if you've ever been told by a doctor that you need to carry an EpiPen, or if you have an EpiPen and have never used it, you're a little bit high risk. Now, the way we manage this, as Dr. Warren deals with this all the time in the emergency room as an emergency room doctor, we know how to treat anaphylactoid reactions quite effectively. But even in the vaccine centers, everywhere I've had my shot, I've had both of my Pfizers, within 10 feet of where I got my shot, there was a nurse with an EpiPen. And that was just in case anybody who had an allergic reaction would have been treated right away with epinephrine. And we know how to, Dr. Warren does this in her sleep. So, but the issue is, if you have a history of documented allergy to nuts, shellfish, etc., talk to your doctor. There's things they can put you on Benadryl and Pepcid and steroids before you have your shot in order to blunt any possibility that you could have it. Or they'll just say, well, let's give it to you and observe you. We'll give you that stuff after, right, Dr. Warren? I'll turn over to you.
Absolutely. No, you hit it right on the nose. I mean, the bottom line is definitely talk with your physician if you have those type of allergic reactions. And then also after you get the vaccine, they're going to watch you for 15 minutes to make sure that there's nothing that immediately happens, because most reactions of that magnitude will happen within the first, 10 minutes. But again, like Dr. Riley said, talk with your physician.
Crystal Gaynor wants to know, should you continue to get COVID-19 tests regularly after you have received the vaccine?
Oh, that's a good question. First of all, you're not even considered total immunity until about 2 to 3 weeks after you receive both vaccinations. So yeah. So you could actually get COVID positive and become positive even after you've already had the vaccine, because it was probably already brewing in between that time that you got your second vaccination. So, I mean, you could definitely get another test. I mean, nothing precludes you from doing that.
Is it
and back to the point we were making before about whether or not you are somebody who could be an asymptomatic carrier who then passes it on to somebody else, you're still potentially that person. So if you want to know if you're that person, I guess that will be the point of getting retested. But the point of it is that getting a vaccine alone doesn't mean that you're not able to pass this on to anybody else. So all the precautions we've been talking about need to be taken with respect to the social distancing, the mask wearing, etc. A test, maybe for your own information, or maybe because someone else is requiring you to have it. Those would be the reasons to get tested, but not necessarily for others.
Right. And I agree. And I think we're going to have to stay tuned for CDC guidance on this. Remember, we're still early in this vaccine phase, and they know they're going to have to address this issue. because first of all, we have to preserve testing capacity, which is still a problem, even a year later, by the way. So again, CDC will probably issue some new guidelines about repeat testing of those who've been vaccinated sometime in the next 2-3 months. So, just stay tuned to see what CDC says about this, but Dr. Vigilance is right.
Yeah. And speaking
Darla,
of,
can I pull a question out real quick?
Yeah, let's pull some questions.
Can I pull one out?
Yeah.
Because
well,
there's
if I can just, I want to just stay here for 1 second and then
sorry.
we'll pull one out.
Yeah.
Dr. Riley, you talked about the CDC guidelines. And one thing I wanted to make sure that we emphasize and don't leave this discussion without having addressed this. The initial protocol for the vaccine was getting the second dose 2 to 3 weeks. Now the CDC has extended that to about 6 weeks because of some of the vaccine shortages. Is there, is it going to be less effective if that second dose isn't in 3 to 4 weeks? And how much time can elapse between your first and second dose? Because there will be concerns about that, because it's realistic that a lot of people will not be getting the second dose within that first protocol timeframe.
Yeah, Darla, this issue has arisen because of the fact we don't have enough vaccine out there, and the CDC and now President Biden and Vice President Harris and the whole healthcare team is trying to say, how can we stretch the vaccine that we have? And as Dr. Vigilance mentioned earlier, even after the first shot of either the Moderna or Pfizer vaccine, you get about 50% effectiveness. The second shot, remember with Pfizer, it's 21 days, they say, later, and with Moderna 28, you get up to 95. But what I think they did, they looked at the data because they keep drawing blood on all the study participants, and they were still seeing evidence of protectivity even beyond the 21 or 28 days, because in a clinical trial, not everybody showed up on day 21, by the way. People missed their appointment and, things happen. So I think that the current evidence is that if they go as far as 6 weeks, you're still going to get good protection. Maybe it's 70%. But the whole reason why they're doing this is that we're just short of supply right now. And again, this is the tough decisions President Biden and Vice President Harris has to make. How do we stretch the supply that we have by spacing out the interval for the second dose and also squeezing out another dose from the syringes? That's the other thing that the new administration is looking at. The syringes, I think, the vials rather hold about 5 doses, right? But the syringes can possibly hold 6. So if you can get another dose out of that vial with the special syringe, you're able to, create more capacity. So this is something that happens when you have a shortage again.
Dr. Vigilance, you said there was a question that you wanted to pull out of the chat box and specifically address.
Yeah, thanks for letting me do that, Darla. And it's a question from a Marjorie who asked about, she's a community organizer for social determinants of health, primarily for dual eligible, so Medicaid and Medicare eligible individuals. How can we help overcome the fear and anxiety Black and Brown communities have regarding vaccine? And I think that part of the reason why this conversation has been so useful, and hopefully if people who are listening to it find it useful, is because it sort of helps break down some of the myths and the stigmas, etc. You as a community organizer should have access to the Medicaid managed care organizations who are providing care within your community. They have providers, community health workers and others, and they have community health educators within their ranks who can help you unpack some of this same information that we're providing you. A combination of those individuals can and should be able to do that. And so I would suggest that you try to connect with some of those organizations. They work for companies that we've all heard the names of before because they are Independence Blue Cross, Kaiser, Humana, Aetna, etc. These community health workers and the physicians and nurse practitioners, etc., who are working within those organizations are a lot of the times very connected to community and are willing to have conversations with community about some of these things. And so maybe as an organizer in the community, you can set up conversations like this one we're having today, but with your local community provider networks. That would be my suggestion, or maybe others want to take that on as well.
Right. Darla,
There's a lot of questions in
Well,
here.
I want to address one because some of them have been covered off the top, and some of them are being addressed right now. Here's one that I've actually never heard of, and I want to find out if this falls into the disinformation category. Gregory Jenkins is asking, why are some vaccines designated for Africa but not Europe and the United States?
right. Great question. It's basically, it's in some respects a cost issue. For example, the Moderna vaccine is probably 34 to 35 bucks per shot. The AstraZeneca vaccine, which is the one that the European Medicine Agency, which is the FDA in Europe, approved, is only about $3 or $4 a shot. So in terms of less resourced countries, where they don't have the capacity for the, the minus 70-degree freezers for the Pfizer vaccine, it may be more appropriate to use another vaccine that has an easier storage capacity. And there's a little trade-off. The effectiveness might only be about 70–75% in other vaccines. But remember, I'm sorry.
Oh, no, go ahead.
Yeah, so again, it depends. It's going to be the WHO, the World Health Organization. Thank God the president put us back in WHO on his first day in office, by the way. The WHO is sort of going to figure out which vaccines will work best in different parts of the world based upon its cost, how easy it is to store, ship, et cetera. So that is a great question, but it sort of depends. Now, again, the nirvana is next year at this time, if we have 6 or 7 vaccines, that is going to be nirvana for the world.
Yeah.
And I want to just stick here for a second because it is such a Herculean task to get so many people vaccinated. I believe you mentioned earlier, it's been mentioned on this panel that we need to vaccinate 1.3 million people a day just to get to herd immunity. And there has been some discussion with regard to maybe bringing in UNICEF, those types of international organizations who are more organized and who have infrastructure for mass vaccine distribution. Do you think there's any benefit to that here in the United States? And if that's even something that would be considered by the Biden administration or health officials?
Well, some of the techniques, I know, this is Dr. Vigilance there, he was the commissioner of health, but we should not depend on hospitals to vaccine people, by the way. Remember, Black folks are scared of hospitals. So no, don't put the vaccine in hospitals. Put it in Yankee Stadium. Put it at FAMU Stadium. Put it where people will feel comfortable going to get the vaccine. Dr. Vigil.
Yeah, I think diversifying our approach to all of this is the key to getting vaccine out to people. I mean, and everyone, the idea that everything that happens with respect to health happens in a healthcare setting is a very ancient way of thinking about health. Certainly great care happens at healthcare settings, but prevention and these opportunities for vaccine distribution, et cetera, can and should happen in a number of different places. And I think it is very reasonable to learn from the lessons of people who have done this very effectively in other parts of the world, in communities with far less resource than the United States.
Absolutely.
To actually take some of those best practices and put them into work here. So I think there's this perception that, well, if we're doing it a particular way in the United States, then it must be the way to do it. Clearly, that's not true. We have failed miserably with respect to a number of different elements of our response to this virus, and can and should make use of some of those lessons learned from elsewhere.
Okay, great. So what I'm going to do, since we have so many questions in the chat box, and a lot of them are very specific to conditions. So if you bear with me, I'm going to just scroll down and I'm going to throw out all of the names of and conditions that are being raised, and you could address those questions maybe at one time so everyone can have their concerns addressed, or as many.
While you're looking, can we talk about Tuskegee? Because I think that's a big issue.
Well, first of all, I'm a graduate of HBCU, Tuskegee University. I do need to throw that in there.
Yes, I remember Tuskegee well. I do want to talk about that, and we're gonna wrap with that because I think that's gonna be the ending note that we want to leave people with today, to make sure we talk about the historic distrust with the Tuskegee experiment, because you don't even know why you don't trust it, but you just know Black folks don't trust it, right?
Treat it right.
A lot of
Treat it right.
We have so many questions. I want to make sure that everyone, as many people are addressed as possible. So we already spoke about rheumatoid arthritis. That was a question from Kimya Jackson. Let's see, who else? Nicole Johnson wants to know if impaired kidney function, would they be safe to receive the vaccine or qualify? Yes. Okay.
Yes.
Let's see, we've talked about allergies a little. What about thyroid disease? Are there any adverse reactions to anyone with thyroidism? That's another question from Brown. Denise McLean wants to know about something that she's been reading. She says vitamin D levels in brown and Black people may play a role in the increased rate of COVID infection in these communities. Can you please address that?
Not an increased rate, but they have noticed a causal, those who have been found to be positive for COVID-19 have a low vitamin D rate. I mean, vitamin D does play a part in immunity and in your immune response. So Black people in general, people of color, don't get a lot of the conversion to vitamin D because we're not in the sun as much. And so our vitamin D levels are not where they should be. So since they found people who had vitamin D levels, that is where they're saying they have, there is a effect with the vitamin D. But no, you need to be taking vitamin D every single day. That should be part of your regimen, not just because of COVID-19. That should be something that we do, and make sure that your vitamin D levels are where they should be at. And that's something that you should talk to your physician about, honestly. That's big.
I take extra vitamin D every day because I don't like milk.
Me too.
But my daughter put me on a mega dose once per week. So there's that option. You don't have to take it every single day if your doctor's going to put you on something to take once a week. So
that's very good to know. We want to touch on adverse reactions because we have reassured everyone that the vaccine is safe, but there are some adverse reactions. Can you discuss what those reactions are? And Claudia wants to know specifically if you can address incidents in Norway where there were some adverse reactions, if you can address that.
Yeah, but let me talk about adverse reactions. I've had the Pfizer vaccine 2 doses. I'll tell you my own personal experience. I'm hypertensive. So I'm high risk because of my hypertension, right? So I got the first vaccine, the first shot. The only thing I noticed first time was my arm hurt for a day. And that's normal. Just like after the flu shot, my arm hurt a day. I slept fine. After the second shot, I noticed my arm hurt, but also had a runny nose. That was it. Now, other people will say they got real tired, they have to sleep it off. So the range of adverse reactions, no one person will have the same reaction. Dr. Warren she had it as well, so she can tell you about her reactions. So that we don't.
I don't want them to think adverse. It's side effects. It's the side effects of the vaccine. It's what it's supposed to do, which is to make you have and feel like you're getting sick because your immune system is working. So you feel sick. You will have the fever, the body ache, and after the second dose will be stronger than sometimes the first dose. Why? Because you already started creating an immune response to the first dose. So the second dose is now like, oh, now you're trying to come back. You're trying to come back and give us some more. We're ready for you now. And that's why by the second dose, you're ready. You're feeling it all. And that's why you're having a lot of those side effects.
So
Arthur wants to know if he or she, should take the shingles vaccine or should be concerned about taking shingles at the same time as the COVID-19.
No, do not take the shingles.
This is a good question. Okay.
Look, take it, but don't take it really close to the COVID. I've taken the shingles vaccine. It's 2 doses, and that's the worst shot I've ever taken in my life, by the way. Do not, and most doctors will tell you.
But there is no recommendation to do co-vaccination with the COVID vaccine. So still continue to do your vaccination, especially your young people. If you have vaccinations that are due, still do those, but not along with the COVID vaccine.
Right.
We have 2 questions, and I think we've addressed it, and I think Dr. Riley did a great job. I'm just going to go back to this again. Adrian Lopez and Kim Sevier, they want to know the minimum age to receive each the Moderna and Pfizer vaccine.
16 for Pfizer, 18 for Moderna. Now, we won't know with J&J. That's the next one that likely will be approved. I have not seen the data in terms of how early.
No data on that either.
Right, Dr. Warren and I have not seen the data, but so as of today, Pfizer is 16, Moderna is 18.
Speaking
And
of,
children are in the next phase. They're being worked on now, so we'll see.
okay, I've got two questions that are going to come from that. Children who have asthma, does that mean that they're high risk and should be getting
Yes,
this vaccine now?
Yes.
once it's approved for children. Now, if they're 16 with asthma, yes.
Yes.
They're under 16 with asthma, no.
No,
No,
Got
Not approved yet.
they can't get it anyway.
they can't be.
Absolutely.
Right. Not approved. Right.
But
So-
once you get approval for a vaccine lower than 16, if your less than 16-year-old kid has asthma, then you should get the vaccine, but only after we get the data.
Darla, can I just say this? Anybody who has a high risk underlying medical condition, whether it's a heart disease, lung disease, obesity, smoking, all the things that you see a lot in our brown and Black community, you need to be vaccinated. And the reason why is because if you get sick, we know that you do not do well. And quite frankly, some of my comrades will tell you, even the healthiest young person that we've seen not do well as well. So you got to get vaccinated. If you're comfortable enough, get vaccinated.
Okay. We're moving on an hour and a half here, so I'm going to just hit a couple of high points and wrap very quickly because we are very, very appreciative of your time. But this is also important to talk about. We have the Pfizer Moderna vaccine. There are two doses. J&J, we know there's going to be one dose. What is the difference? That question has come from the floor.
Dr. Vigilance, do you want to take that? The Johnson & Johnson? Yeah.
I mean, the degree to which a vaccine is effective is just basically how much of an immune response it can actually get your body to kick into with a particular dosing amount. It's the way that it's worked so far is it's required a 2-dose regimen to get from 50% effectiveness to 95% effectiveness. This new vaccine, J&J, is going to get, I don't know what the percentage is it gets you to immediately, but it does apparently do a much better job of getting you up to a more acceptably high level of effectiveness, meaning that you have generated enough of an immune response that you are considered protected after a single dose. And that's just not the case with what's been made available so far. And what's been made available so far was made available on very short order. And now as we get more sophisticated with respect to what we know we need to be putting out there, it's not surprising that we're moving from a 2-dose regimen to a 1-dose regimen.
But there is no difference between the Moderna and the Pfizer as far as the percentage that you get after your second dose.
Right, those are the same. Those are exactly, what I was saying was I don't know what the effectiveness is going to be after that single dose of the Johnson & Johnson. Yeah,
absolutely, absolutely.
Right, and that's why we're waiting for the data. All three of us want to see the data on J&J. Now, let me just sort of surmise from the preliminary reports, even if J&J is 70% effective, let's say, that is still very good because guess what? The flu is only about 55% effective every year. So again, the beauty of a 1-dose vaccine, I think this could be very helpful for vaccine hesitant folks. If they say, well, I only got to do 1 shot instead of 2. And for younger people, for particularly college age students, high school students, where you know it's hard to get to them do anything, that may be the vaccine ultimately that we say, let's give to the tweens and teenagers and early adults. So again, once we get more vaccines in the market, then we'll be able to slice and dice and say, Pfizer's better for this group, J&J's better for this group. But for right now, as of this hour, we only have 2, and that's Pfizer and Moderna. We hope to have 3, hope to have maybe Novavax or AstraZeneca in the summer. But as of now, we only have 2. We're looking very much forward to the J&J.
Okay. I want to, again, wrap up with just a few quick questions. Carolyn Mason wants to know, is there a heightened risk of adverse reactions in children with epilepsy? She says she's particularly concerned given the somewhat rare multi-system inflammatory complications that have occurred in children who have been diagnosed with COVID-19.
Well, again, we're waiting on the data for children. We just don't have enough data in terms of vaccine, but we do know, as Dr. Warren has seen in the emergency room, there have been some kids who came in with this this multi-system inflammatory disease. We had cases as young as 2. 2-year-old baby had it. The good news is they tend to respond and do well with treatment. But again, this is because of the COVID itself, not because of a vaccine.
Okay, great. And Tahira wants to know, can someone paint a picture of exactly what COVID-19 looks like in children? We know that sometimes the data shows that they may not become as sick, but you do have this multi-inflammatory syndrome. So can you paint a picture of what that looks like for children and what the regimen
Dr. Warren is in the emergency room, so.
Sure. I mean, so part of the issues that we're seeing, and even I want to add this too. Part of the reasons that we're seeing is that the COVID virus attacks the body, right? And you get this immune response. You get this over-exaggerated immune response. And so what we're seeing in young children is that this over-exaggerated immune response is what they're having systemic responses to. And it is seen in more of the young people, but what we are seeing in adults too is the post-COVID type of stuff. And that also is what is being a concern as well. It's like, you know, COVID also causes you to have increased coagulopathy. Well, the reason to clot. So you can get a blood clot in your lung. You can get a blood clot in your brain and cause a stroke. You can get a blood clot in your heart and cause a heart attack. These people are coming back, and these are the patients that did well, that passed the COVID. They're still coming back now with these symptoms of chronic cough, shortness of breath, headache, feeling really retired, having the post-COVID memory fog, which we call the post-COVID fog. And so I guess to emphasize, it does everything.
Right.
And I mean, from the rooter to the tutor, the COVID virus does it. And so what we see in kids is the auto-exaggerated immune response. And what we're seeing in adults is this post-COVID type of symptomatology that's bringing them back to our emergency departments or to their physicians.
And this is why we say the effects or the side effects of getting vaccinated pale in comparison so significantly to all of these concerns that are being articulated here clinically. Nobody wants anybody to feel or experience the things that we're talking about, let alone the most inconvenience, the most significant inconvenience, the worst outcome is just death as a result of having contracted COVID. So whatever you have to deal with respect to some discomfort, some runny nose, some headache, and some of those other things, and not to dismiss those things as nothing, but feeling bad for a few days, choose that over some of these long-term, very, very serious
heart failure, everything. I mean, this COVID is no joke. It is no joke.
And just to underscore, I'd rather have a sore arm for a day or 2 than to have a stroke.
You know, and so just the volume of questions that we have and the expertise and the knowledge that you all are sharing with everyone just lets you know how important this is and how important this information is. And I want to thank everyone for jumping in. Elaine Brown, Norma Mackey, they said it was great information so far. So we could talk about this for such an extended period of time, but we're almost at 2 hours now. So I want to be respectful that it's a Sunday night. It's a school night and we all have to work tomorrow. Sharonda, Fred, they're all grateful for the information that we have. As we wrap up, I do want to address the Tuskegee experiment. To your point, Dr. Riley, can you speak to that briefly and how that has grandfathered into just systemic mistrust in the healthcare system in the United States and what you're doing to combat that, in particular with this COVID-19 pandemic?
Right. Well, thanks. And I'll need assist from Dr. Vigilance and Dr. Warren. Let's make sure we understand what happened at Tuskegee, because I think the first thing that people misunderstand is that there's a feeling that the United States government, in the form of the Public Health Service, gave Black men syphilis in rural Alabama around Tuskegee, Macon County. That is not true. The United States Public Health Service found about 600 men in rural Alabama who had syphilis, but the problem was they did not treat them. They did not treat them, nor did they tell them that they had syphilis. And in fact, they should have treated them when penicillin became the definitive treatment in 1948 for syphilis, but they never did. The study went on from 1938 to 1972. Now, our history is complicated as African Americans. The other thing we have to understand, Black doctors and Black nurses were part of Tuskegee. The autopsies on the men were performed at Tuskegee's hospital, the John A. Andrews Hospital. The then president of Tuskegee, Robert Moton, supported it because they saw it as a legitimate way to get federal money into Tuskegee. So this is complicated, guys. And now you say, what was the residue of Tuskegee? Well, the residue of Tuskegee is we now have informed consent. We have IRBs. There is little chance that a Tuskegee could happen again.
No, absolutely. No, continue on. I was just backing you up.
No, so again, we have to understand the unethicality. Let me make sure I understand the unethicality about Tuskegee was they never told the men they had syphilis. They never treated them with penicillin once the FDA approved penicillin as the definitive treatment, and they hoodwinked the men for 40 years. And never told them. All they said was bad blood. Now, these men were semi-illiterate and et cetera. And that was the danger of Tuskegee. It's not that they were given syphilis. Now, it would be equally unethical of us in this day and age if we have good vaccines that we were not offering to African Americans and Latinos.
That said, that's why it's important for us to have this panel to be as transparent with information as possible and to have distinguished physicians like yourselves with seats at the table so that everyone who has joined us for this panel and beyond will have confidence in the process. As the last thing, which you never can say it enough, we've definitely, I think, imparted how safe the vaccine is, but what can they do? Remind everyone on this panel as we close out, what is the best prevention from contracting the COVID-19 virus?
Mask, wash your hands, and socially distance. We can't say that enough.
Yes, and even if you get the vaccine, you still need to do those things.
Get the vaccine when your number's called, get the vaccine. But Dr. Warren is right, Dr. Vigilance is right. We have to still do. Look, I miss going to church. I miss going to football games. I miss going to my Alpha meeting, my Boule meeting, all that. I know y'all miss going to Lynx meetings, but we can't do it now.
Mask up, right. Mask up, mask up.
Absolutely.
Well, Dr.
It's not all about you.
Taking us to church on this call. We will make sure we seek you out when we can go out.
All us doctors have preaching degrees, just a different type.
Right.
Again, this has been indeed a pleasure to have this discussion with the three of you. Thank you so much, Dr. Pierre Vigilance, Dr. Karma Warren, and Dr. Wayne Riley. We just are full with the information. Pleased we could talk all night, especially with Dr. Riley taking us to church. But I do hope it has provided some valuable information. We're getting some feedback that it has. It's a lot of information. It was 2 hours, and I want to let everyone know that this will be available on YouTube tomorrow, so you can share with friends and family who are not able to join. And on behalf of the Essex County chapter of the Links Incorporated, and myself as a member of the Bergen County chapter of the Links Incorporated, again, we thank the three of you all for sharing your wisdom and for having a seat at the table and representing community of colors in this in this very important time in history in this pandemic, so that we make sure that this healthcare and pandemic and the vaccine, there's equitable distribution to persons of color. So again, I believe, we're all very, very grateful for your expertise. And to all of you who are still with us, more than 200 people still on the call, thank you for joining us this evening. Stay safe, mask up, get your vaccine. Again, I'm Darla Miles with WABC TV in New York City. Thank you for your patience.
Thank you.
Good night. Be safe.